Good afternoon, everybody. Again, my name's Krista. I'm happy to be here with all of you. And I have been a nurse at Providence Sacred Heart Medical Center for about 30 years. And all 30 of those years have been spent in our adult intensive care unit, our neurotrauma unit. I also spent some time working at the Heart Institute. And so I had the pleasant surprise of seeing Dr. Notsky walk in. I haven't seen him in a long time, but he and I shared a lot of days and long hours together at the Heart Institute in my time there. So that was fun to get to see him. Okay, I'm going to go through our, is this going to work, Travis? That's fine. Oh, it will, okay. So these are the objectives I have lined out for today. To describe the purpose and the implementation of our Region 10 concept of operations, talk about just the collaboration that's happening amongst the 10 regional treatment centers in the nation, and how that affects all of us, trickling down to the local level. Turn what on? This? Oh. You guys got a rookie presenter here. Here we go. Okay. I think I got everything set. Kind of talk about a patient's journey through the special pathogens unit, talk about a lot of the preparedness and training and exercises that we have done over the last year and a half, and then talk about resources that are really available to all of us through the National Ebola Training and Education Center. Okay, I just threw this slide in as a quick review for all of us of really the tiered structure system that was set up after the Ebola outbreak in 2014 of frontline healthcare facilities, assessment hospitals, and treatment centers. And so the frontline healthcare facilities, really their job, all three facilities' jobs, if necessary, is to identify, isolate, and inform with a goal time of 5 minutes or less. And so that's really the focus for frontline healthcare facilities. And then they need to have personal protective equipment for at least 12 to 24 hours of care for a patient. Then their job is really to package that patient up and transport them, if that's deemed appropriate, to an assessment hospital. And we have 6 assessment hospitals, I think that's correct, in the state of Washington. And they need to have personal protective equipment for up to 5 days, and the ability to draw labs and coordinate testing to see if that patient is positive for Ebola. And then treatment centers, we have 3 of those in the state of Washington, so Harborview Medical Center, Seattle Children's Hospital, and then Sacred Heart. And then we are a regional treatment center for the states of Alaska, Idaho, Oregon, and Washington. So one of our jobs that we've spent a lot of time over the last year and a half is really working on the concept of operations for Region 10. And I guess in a nutshell, it's a document to really guide all of us and all the important agencies that are involved in transporting a patient from that patient's state of origin, where they originate, and how if they need to come to the treatment center, how they get to us. It's a lot of coordination, and I'm just going to kind of highlight some of the things, and I will, Daryl, if you have anything to chime in on as we go through this. Daryl's really good at this ConOps stuff. He gets into it a lot. The purpose of the ConOps is really to establish roles and responsibilities, inform partners, communicate our capabilities, and provide that high to mid-level guidance, and just all the coordination that takes place with all the agencies involved. It's not intended to provide any tactical procedure to anybody or really stand alone. It's really a guiding document, and we all have our own plans and procedures that we put into place for this work. So it's not intended to substitute for any agency's specific procedures or plans. We assume that all regional partners use the National Incident Management System to coordinate operations, and that they'll be conducted following CDC guidance, and that all states maintain capabilities to take care of Ebola virus or other special pathogen patients, and that states, EMS agencies, transports agencies, hospitals all maintain their own plans and procedures. But this is a voluntary work, so all partners must be in agreement to conduct a particular transfer. So it's a lot of coordination. So basically, the basic process is a patient's identified at a frontline facility or an assessment facility in a state, and then their responsibility is to notify their local health jurisdiction. Their local health jurisdiction notifies their state Department of Health, and then the HHS regional coordinator gets involved, and the Washington State Department of Health gets notified, who then notifies the regional Department of Health at Spokane, and then they notify us. So a lot of coordination and communication that takes place. So that's kind of it in a nutshell. We do have, oh, I thought I had the infographic next, but here the regional coordinator notifies ASPR that if there's an air transport that is required or necessary, they are the ones that contact the Phoenix Air Group, which is the flight transportation service that has the contract with the State Department to transfer. And they are the ones that provided transportation internationally for patients during the outbreak to Emory University and to University of Nebraska Medical Center. And they have recently said they are going to do domestic transport. So we're actually in the planning process right now for a federal full-scale exercise that's happening in September, where Phoenix Air Group will be involved, and they'll be transporting, I think it's a total of 7 patients involving 4 of the regional treatment centers. 4 of those patients will be transported out of Boise and brought up to Spokane, where they will drop 2 off here and take the other 2 down to Cedars-Sinai, which is the regional treatment center for Region 9 in California, in Los Angeles. So we're working through a lot of these details as we did a full-scale exercise in May, so we're working through a lot of details within this CONOPS of lessons learned then, and also working through more as we are identifying more as we plan for this next full-scale exercise. So I put in several conference calls are held because it's more than just these 2, but once Sacred Heart has said, yes, we're going to take that patient and officially accept that patient, then we would have coordination phone calls that happen, one from a clinical perspective and one from a logistics perspective of coordinating all that transportation. And then we have also a policy phone call and a public communication call. So this infographic is changing really quite a bit, but I don't have the updated version of it. So these red stars are kind of when we did our exercise in May, we realized that we kind of left out this really important piece of the Washington Department of Health notifying Spokane Regional Health, and the fact that Sacred Heart has to say, yeah, we actually do accept this patient before we proceed through any of these other steps. So we've spent a lot of time the last few months really working out those details. So just an overview of the responsibilities. So the facility of the patient origin is to treat the patient, request transfer, and provided any necessary information to us at Sacred Heart and any other partners involved in the care of that patient. The health jurisdiction in the state of patient origin would be to coordinate with the Department of Health and local partners to arrange for transportation, security, and any appropriate waste management. And then the air transport provider would provide safe air transport and coordinate with the receiving facility to solve the logistics of what time. There are always quite a few ethical issues involved in this care, but you know, the overarching kind of guidance policies we have is that care should not be delayed to that patient. Risk must actually be the risk to all the healthcare providers balanced with how do we provide safe care to that patient, and how do we expose the least number of healthcare workers to that patient. So clinical decision making needs to be made based on the patient's needs, but also balanced with those decisions of not exposing a lot of people. Waste management, so category A waste management, which I won't go into a lot of detail, but it's very tedious and has a lot of regulations from the Department of Transportation, a lot of guidance from the CDC. So that can be a big challenge if you're talking a ground transport. That's why we're looking at these air transports for longer drives, because it would be really challenging to drive somebody on an 8-hour ground transport, having to change out healthcare workers after they've been in PPE for 4 hours, and then what do you do with all that waste and handle it appropriately and safely if you're meeting somewhere for kind of an exchange. And so a lot of challenges along the waste management. And then mortuary affairs, if somebody does expire, you know, the viral count on an Ebola body, a deceased patient with Ebola is at its highest when they're deceased. And so there's a lot of guidance and very strict protocols and procedures that have to be followed when somebody has expired. And so our stance at Sacred Heart is if somebody was on their way to us and expired in transport, we would just want them to continue that transport, not stop, bring that patient to us, as we will be best equipped to have the knowledge and really the necessary equipment needed in order to package that body appropriately. Okay, so this is a map of the regional treatment centers and just where they're located. Massachusetts General is up here in Region 1, and Bellevue Hospital in New York City. Here, Johns Hopkins University and Emory University. University of Minnesota Medical Center. Nebraska, University of Nebraska Medical Center. University of Texas at Galveston. And Denver Health, Cedars-Sinai, which I mentioned earlier, and then us up here in Spokane. So one of the really exciting opportunities and really educational opportunities for me personally, but for all of us at Sacred Heart, has been the collaborative work amongst the 10 regional treatment centers. And so we do have an annual summit, and we just had that in the end of June. And we spent some time talking a lot about some of the highlights from that is there was a breakout group of the medical directors all getting together from the 10 regional treatment centers saying, can we come up with a master list of what are those pathogens that all of us will say, yes, we want in our unit or we will take in our unit. And so they made a lot of progress towards that. A lot of talk about transportation, about exercise planning and developing. So really everybody coming together and sharing their best practices has just been a really great collaboration that's taken part. We have the benefit, those of us that have not had a patient have a benefit of really learning from the experts at the 3 treatment centers that did take care of a patient, or 1 or 2 patients or more. And so they have just really been great coming alongside us and sharing their best practices, their experiences, so that as we develop our programs and our plans and procedures, we are able to really come together and do a good job in getting prepared for these patients. This picture here and this picture here are from the first tranquil exercise that happened in, I think this was January or February in Nebraska, where they brought 3 patients back from Sierra Leone to University of Nebraska Medical Center. And this picture here actually almost didn't happen because the winds were over 50 miles an hour 20 minutes before they opened the nose of the 747 to use that K loader. So they had to really come up with a contingency plan about 20 minutes before the arrival of the airplane. And then the winds kind of died down and they were able to exercise that. So we're hoping to do this exact same thing in September. That's what we're working towards. A couple of other things that have been a real great part of this collaboration with the other treatment centers is having people from our region being involved in site assessments at other hospitals within our region. So Daryl and myself were actually invited by NETEC to join them at site assessments in Alaska on Kodiak Island for a frontline facility, and then in Anchorage at their assessment facility. And so that was just really a great opportunity for us to go up and join with NETEC, where we did kind of a joint educational time and site assessment at both of those facilities. And we really benefited from establishing relationships with people within our own region and really starting those conversations and addressing the challenges of how would you transport a patient from Alaska down to Spokane. And then we always just learned, you know, they learned from us, we learned from them. It was just really a great experience. And then that's really what springboarded our planning process for frozen contagion, which was our full-scale exercise we did in May of this year, which I will talk about in a few minutes. We also have, they've also started a research network, I want to point out, amongst all of the 10 treatment facilities. So those patients that were here during the outbreak received experimental medications and therapies, and so they're working hard to kind of go through the whole laborious institutional review board process to have a lot of those pieces in place, that if we did get a patient, we'd kind of be able to just pull the trigger to get those therapies sent to us quickly. A little bit about our journey here at Sacred Heart. So we applied for the grant in June of 2015, and we were awarded that grant in July, and then started with some committee organization in September, and community, committee with community involvement, and then also committees within our hospital to address the operational part of our coordination. And then my position was created in November of 2015, and we started training the team and really coming up with a plan for education and preparedness in January. And then the renovation of our unit began in June and then completed in December. So we took a unit that had most recently been used as a pediatric overflow unit on the east, the lower second level of the east addition of the Children's Hospital at Sacred Heart, and renovated that space. And then that completed in December, and we started accepting overflow patients in January. One of the things is, it's a really big space. We didn't want that space to sit idle. And as you all are well aware, as he mentioned in that study that's being done, diversion hours and capacities is a real challenge. And so we've had patients down there pretty consistently. I think maybe 3 weeks since January, there haven't been patients down there. And so we're able to kind of cordon off a space for us to use for training as well while we have overflow patients down there. So it's really the best of both worlds. As we got close to the renovation being completed, we really identified the need that we needed to communicate just what this unit is, what our capability is, why we chose to go down this road.
In 2014, things changed in the United States with the first presentation of a patient with Ebola in Texas. And hospitals across the country were faced with trying to be ready for any kind of interaction with a patient who potentially would be infected with the Ebola virus. We were encouraged by both the Washington State Department of Health and the CDC to apply to be the Region 10, Alaska, Washington, Oregon, and Idaho Center of Expertise for Special Pathogens. By serving as this regional center for the country in this way, we have the opportunity to partner with remarkable medical centers, Emory University, Massachusetts General, Cedars-Sinai, many others. And that's really been a remarkable advantage to be able to share ideas and concepts and procedures so that we can all prepare the same way. One of the other key imperatives was to be able to provide care for all age groups, and that included pediatric patients. And the unique thing that we have here at Sacred Heart Medical Center is this expertise of the Children's Hospital. So we would be able to care for children here as well.
Both adult and pediatric physicians are integrated in this process. There's adult critical care as well as pediatric critical care and infectious diseases. We have ongoing training and meetings regarding special pathogens and how to deal with them and how to integrate these services to provide the best care for patients with special pathogens and protect the staff and community.
We have a team of 35 caregivers consisting of nurses and respiratory therapists who go through regular training, drills, and exercises. We also incorporate the different departments in the hospital with workers from the Environmental Services Department, from security, and we include our workers from the lab so that we are all practicing and training regularly all the protocols that we've put into place to keep everybody safe as they care for a patient that's highly infectious. We have a 12-bed unit where each of those rooms are negative airflow rooms or airborne infection isolation rooms. And then we also have a lab that's designated for our special pathogens unit, and it is also a negative airflow lab. And then we have 2 rooms that are critical care rooms, and each of those critical care rooms have their own doffing rooms. We designed the rooms specifically so that we would have good visualization of our patients and also of our healthcare workers so that there's somebody observing them all the time to make sure they are safe. In the event that we needed to run lab work on our patient, we have a lab here in the special pathogens unit that is designated just for this unit. The labs would be brought down in a cooler down the hallway and put through a special pass-through window, and then we would have 2 lab technicians in the lab being able to perform the tests. One would perform the test while the other one would be monitoring that lab technician to make sure they were safe. The uniqueness of this unit is it is physically situated away from the mainstream of the hospital, away from the hustle and bustle of the emergency department and the main entrances of the hospital, so that it is very secluded and it's secure to keep our healthcare workers safe and to keep that patient safe and to keep the infectious patients away from the other patients in the medical center. It is a locked unit in that the only people that would have access to the unit in the event that we were activated would be the actual team members who have gone through all the training of how to care for a highly infectious patient. Okay, we are prepared to receive a patient within 8 hours of notification, but the likelihood of us receiving a special pathogens patient is pretty low. So we don't want this space to sit idle. So we can use it for training and education purposes, doing drills with our team, but we can also use this space for overflow for the hospital when there's high census.
We know that infectious disease patients are going to come no matter what, and with the extra level of preparedness and safety, I believe that we can care for the patients safer, not only for the community, but also for the caregivers.
Our mission is to care for the poor and the vulnerable. And our country, our patients, our community could potentially be vulnerable for any special pathogen. You can never control what's going to happen or what presents at your emergency room or your clinics or your urgent cares. Planning to be ready to get someone and to have expertise in the field and access to other experts was the right decision for us, which has culminated in the new Special Pathogens unit here at Sacred Heart Medical Center.
Okay, so once we say, yes, we're going to take that patient, then the whole process starts at Sacred Heart. So the activation of the unit, the call comes through the Admit Transfer Center. It's really the same process we follow for any other patient that a facility wants to send to us. We just really wanted to keep that process the same. So they call the Admit Transfer Center or the ATC, and we have a collaborative decision made with our medical director, with myself or whoever's the lead nurse for the unit at the time, administrator on call, and administrative supervisor to really say, is there anything else major going on in the community at Sacred Heart where we feel like we can't take a patient? And then we have, since we do have overflow patients down there, we have up to 8 hours to relocate those patients. So we have a whole process in place. That's the first thing obviously we'll do is move those patients to other places in the tower and activate the team and then bring them in, and we have a whole process that involves many of the departments within the medical center to get that space ready and to get all the supplies and equipment and everything in place. This is obviously a picture of Sacred Heart, but this red arrow is pointing to the point of entry of where a planned admission comes in. So we have a patient that we know is arriving to us from another facility or from the airport. This is where they come in, is on this division street between 7th and 8th Avenue. And during a planned admission of a patient, we do work with Spokane Police Department, where they close off a section of this road so that we can control that that space so people can't get in and watch, and we don't have extra issues on hand to deal with. As you can imagine, and that I've mentioned several times, there's a lot of logistics involved. So the transportation coordination, a lot of airport details. We did use the airport during our full-scale exercise in May, but bringing us 747 in for this exercise in September has a whole nother set of details that we are working out with Spokane International. A lot of coordination of the communication and messaging between our public information officers takes place between Sacred Heart and between Spokane Regional Health District and the City of Spokane and Spokane International Airport. So they kind of had their own set of planning meetings as we approached our full-scale exercise in May, which was really beneficial for really shaping the message that it's a consistent message to the community from all agencies. These are pictures from that exercise. So this is when we're offloading the patient in the isopods, which is it has its own negative airflow system in. So one of our team members volunteered, and so she was in there for the whole time. And this is them offloading them at that point of entry that I pointed out with AMR. So our unit is large. It's about 14,000 square feet. We do have 12 rooms that are all negative airflow rooms. Every once in a while. Oh, okay. Thank you. We have 2 critical care rooms that are really can have the same equipment and capabilities to provide the same care we do in any of our intensive care units. They do have doffing rooms attached to them. And then we also have a video monitoring system that we use for communication. And we have video cameras set up that we have a nurse that's always sitting out at the desk that can watch those video cameras and also communicate with the people in the care room or people also in the doffing room or with the people in the lab. We do have 3 shower rooms for the caregivers and then the lab, which was talked about in the video. Okay, this is a footprint of the unit that I put in. And so over here is the elevator that the patient comes up in. And then it's just a really short little walk to the entrance of the unit. So all this area in white would be completely locked down from the rest of the hospital, and the only people with access would be members of the team. I don't think anybody else would really want to come in anyway, yeah. This hallway here and this hallway here are really considered what we call warm zones, and then this doorway to this doorway is cold. So what that means is you don't have to be in personal protective equipment in the cold area. So our staff would enter from this door, come into this room, put on all their personal protective equipment, enter the unit this way. These are our critical care rooms here. And then once they go to the doffing room and doff out, then they walk down this way, shower, and then they're back in the cold zone. So this just kind of further defines those hot zones. So the hot zone is really the area in the patient room where the waste management is kept and in the lab. And the warm zones, the nurse's station and the hallways within the unit. And then the cold zone is that area I pointed out. So our team, we have 35 people on the rostered team, mostly nurses and 2 respiratory therapists. They come from a few different units in the hospital. The intensive care unit where I work, the cardiac intensive care unit, and the pediatric intensive care unit. And then we have 9 people from the lab that have volunteered to work in the lab, and they're part of our team, go through our regular trainings with us and exercises. And then we also have people from our environmental services department that they are very key players in the waste management and transport of that waste to the appropriate areas to be stored, and also in cleaning behind when a patient's being transported through the facility. All of our nurses are trained in advanced cardiac life support and also in pediatric advanced life support, and have the ability to do continuous renal replacement therapy, which was a very important therapy for some of those patients when they were here during the outbreak. They do all go through a yearly health medical review, mostly to just make sure that they are okay to be in PPE for up to 4 hours. And we have an agreement with Providence Occupational Medicine if somebody needs further testing or evaluation to make sure that they'd be okay to be in that PPE. We send them there for that at no cost to them. And then we work closely with our employee health department for our employee health monitoring system. These are some of our environmental services workers during one of our exercises last year. So anybody that is exposed to a patient, whether they're caring for a patient, handling lab specimens, or managing the waste stream, they would go through a monitoring system. We do have a SharePoint access drive that they can access from home or from the hospital. And then we do have backup systems in place if they don't have internet access, that they can call in, and we have several different backup plans in place for them. But they would be responsible for monitoring their temperature twice a day for the whole duration, so 21 days from their last day of exposure, and also whether they have any signs and symptoms. And then we work with the Spokane Regional Health District in reporting all of that information. So training and education. This is the really fun part. So personal protective equipment, what is it? It is, by definition, equipment worn to minimize exposure to workplace injuries and illnesses, but really identifying when is it necessary, what pieces are necessary, what pathogen, do you need the same PPE for every single pathogen? Maybe not, but if it can be very challenging to have a different outfit for every pathogen. It can be expensive, it can be confusing for the staff, and make training really challenging. So there's a lot of things that go into deciding what you're going to have, and then in training on the properly putting it on or donning or taking it off, which is the doffing process. It is something we do and use every single day, and I think one thing I've certainly learned, and I think everybody in our team would agree, that we've realized maybe how well we don't do it. That we do it every day, but maybe we didn't use it correctly, maybe we didn't use it appropriately, and we probably certainly didn't take it off appropriately. So really going through all this training and education has really improved everybody's personal practices in their home units, as well as preparing us to have that PPE on at a higher level for a more highly infectious patient. These are some of our physicians there. 2 of our adult intensivists. They take more selfies than everybody else on the team. They're in their PPE. There's always a pause in training for everybody to pull out their phones and have me take pictures of them. So this is a picture I like to point out this is from one of the NETEC trainings. And so when you go to a training that NETEC sponsors, you ship your own personal PPE there, and then everybody has their own get-ups, and you go through usually a skill station type thing or a simulation training. But it's really a great opportunity to see everybody's wearing something completely appropriate and necessary, but it all looks different. And so I like these pictures to point out you don't have to have the same jumpsuit as the people at Emory University have. And a lot of things drive what PPE you need. And a lot of it has to do with supply chain and what items are available to you. Obviously, expert guidance, disease transmission, staff safety and comfort. So we made the decision to wear PAPRs, so the powered air purifying respirators, instead of an N95 mask and a face shield. Those N95 masks and face shields are really hot. And so during one training, we found that the face shield just fogged up and people couldn't see. And so even though a PAPR may not be completely necessary, depending on the patient's clinical condition, if you're in it for 4 hours, the staff felt it was necessary for their comfort. So that's why we made that decision. Watching a lot of videos from the experts at NETEC, talking with people, I think really the most important thing in PPE and in donning and doffing is understanding why you were doing what you were doing. It's not so much of, oh, which glove do I take off first? It's more, why am I taking this off at this point in the process, and how do I take it off? So that's really what we try to emphasize with our team. So we do quarterly donning and doffing training, and really practicing over and over and over again is really what's necessary to make people proficient at it. It's a very slow process. The first time you put somebody through that training, they're just like, seriously? This is going to take 30 minutes for me to take this off? But sometimes it can, and especially when somebody's new at it. And always having a skilled observer is an essential piece. These are just examples. This would be PPE for a dry patient. This would be PPE for a wet patient. So somebody who has a lot of bodily fluids, you just don't want to have any skin exposed at all. So different strategies we use for training is like competency-based assessment, drills and exercises, whether they're tabletop, functional, or full scale, and then train the trainer programs. One of the things that that I'm doing this year is I've identified, kind of created a new position called the Special Pathogens Unit Lead, and really there's 6 nurses on our team that have agreed to take on this role where they are going to come alongside me and really become the experts in donning and doffing, helping in training, helping me plan exercises. And so it's just kind of that next step in our team development. And so they are very engaged and excited and are very involved in the process as we go through getting ready for Tranquil Terminus. So that's been really, really fun to see. And then having a just-in-time training program, basically a plan that, hey, we're getting a patient tomorrow at 4 o'clock. So how are we going to get everybody up to speed between now and then? Not something that just happens overnight. So we do participate in NETEC educational offerings. In fact, I'm sending 3 of our pediatric ICU nurses along with a pediatric intensivist down to University of Texas Children's Hospital in Houston just in a couple weeks. And so they're going to go through 4 hours of skills training, some didactic learning, and then also a simulation that they have no idea what the situation is going to be. So they'll come back with just a wealth of information and be able to share that with all of us as we develop our standard operating procedures for our pediatric patients. Quarterly exercises, I've talked about that already, but we always try to incorporate donning and doffing into that. With a lot of skills-based exercises are really valuable for the team. We did one last October where they were in PPE for the first time up to almost 4 hours. I do try to have monthly contact with the team. One of the things NETEC has started is an online education system, and so they put an online about an hour-long course on their website just in the last couple of weeks that I was able to assign my team to, and then they're able to get continuing education credits for that as well. And we really focus on no hierarchy at all with our team. It's just everybody needs to know, regardless of what their role is, if they're somebody working with the waste management from environmental services, a nurse on the team, or a physician providing guidance, that we are all on an even playing field when it comes to keeping each other safe. So it's very important that everybody on the team feels empowered to stop somebody during the doffing process, and that person follows the instructions of that person that just stopped them. All with that understanding of we are keeping each other safe during that. These are some pictures of our skills training last October. This is chocolate pudding, in case you're wondering. One of my claims to fame is I put a bunch of chocolate pudding in ketchup bottles, and we were going through one of the stations was changing, just doing a whole bed linen change, something we do every day, don't think about it all in our day-to-day units and jobs. But when you're doing it, a lot of liquid stool secretions from an Ebola infected patient, it takes on a whole new meaning. And how you do a very simple process that you normally don't think about, you also all of a sudden have to think about. And so then we'd pull out the chocolate pudding and squirt them in the middle of it. It was fun. So really a culmination of a lot of what I've talked about came together during Frozen Contagion. So this was a full-scale exercise we did in May of this year. And I like to highlight it because it really was a collaborative effort of things we learned from NETEC and over the past year. We did it while NETEC was at Sacred Heart for our yearly site assessment. So we had their expertise and ability to watch our exercise and really learn from them and get their input. And then just all of the collaboration that we have done with our community partners and everybody, just it was really great to see all the community agencies come together and collaborate on planning this event and building our relationships and increasing our capabilities. Okay, so resources available to all of us. I want to point this out that NETEC has just a wealth of information. I feel like their website just has kind of blossomed in the last 6 months, and they have a lot of resources around exercises, links to Bellevue Hospital in New York City, to University of Nebraska Med Center, and to Emory, all their protocols, all their videos, standard operating procedures around all this work. And then they are fully funded, that if an agency wants them to come and do an assessment of them, they can just say, please come, and they'll be there. And you can really tailor what you want to be assessed at your hospital, or if you have an educational need, or if you have a very specific training you want to do, they are more than willing to work with you to provide really whatever your facility needs in order to improve your state of readiness. So I highly encourage you to check out their website. I think that's my last slide. Here's my contact information. More than welcome to contact me with any questions, or if you want a tour of the unit, I'm happy to give you a tour. So I'm the person to contact if you have that request. Any questions? Yes, Travis. Sure. Right. So the question was, what have we done at Providence Sacred Heart as far as that frontline facility capability? So a patient that comes in through the door that is a person under investigation. So we've done the emergency department has done some training as far as that identify, isolate, and inform, and we have a very specific protocol of what they do, how they have that travel screening question that's a part of our electronic health record. Right when they walk in the door, the first nurse they talk to, that question is asked. They also have the ability to self-isolate. So we have signage up there for somebody that comes in. If you have a fever, it asks these questions. If you have these symptoms, and then there's masks right there for them to put those masks on and self-isolate. And then once that first nurse, if they recognize that they have a positive travel screening and positive symptomatology, then they have a place where they isolate them right away, and then a whole chain reaction of notifications takes place from that point on to get them isolated in the appropriate room in the emergency department, and then start the process of really diving deeper into, is this really a potential patient that we would put in the unit? Does that answer your question? All right. Any other questions? Yes.
The classes that NETEC does,
Yes.
How specific are they to Ebola, or are they much more wide-ranging than that?
I would say they are branching out, as we all are, into things beyond Ebola. They will do specific things for Ebola, but really the whole focus of NETEC and all of us are really what pathogens are we most likely going to see in training for those. So I would say they do both. Our training over this next year is going to take a shift from Ebola and focus more on respiratory pathogen patients and a higher number of patients. So we exercised 1 patient. In September, we're exercising the arrival of 2, but really, we're really going to branch out into those airborne illnesses. And, what if we have 5 MERS patients come into the unit? What does that look like for training, for donning, for doffing, all of that? Does that answer your question, Nick? Anybody else? Okay, thank you very much.